Anh ơi, hai chú switch back the host vậy? Nằm chỗ nào?
You just
Em
click,
đã ngu.
just right click my
Em
name.
đã ngu IT rồi anh còn giao việc cho em nữa.
Now, just in case, you know, because you have to lead those things sometime in the future. So just right click on my name and then make me the host.
Right click on your name.
Yeah.
Oh.
You know, on like the VietMD thing. Yeah.
Yeah.
And then just
make host. Okay.
yeah, make host.
Oh, I can make you a co-host, so you can.
Yeah, you can make me a co-host too. That should be fine. Yeah. How's school?
Yes. Don't know. This block is brutal. I got a pharmacology this block, and afternoon I like the neuroscience, so it's terrible. I mean, I sit in the lecture, I just look down and write no, and I look up and then like it's
so
God.
I know the techniques is that when I go to lectures, I just pay attention to make sure that I understand the lectures instead of spending all the time writing the notes. It usually doesn't help.
I like the lecturer doing like some of the professor like write down note for us, so which is good. I had me like pay attention. However, like some of the note were like just like picture only. So for example, today we have like the CNS, like the neuroscience, and it's just all the structure. So if I don't like mark down, kind of don't know what I'm looking at. But they have a recording session, so I'm just gonna listen to record it again. The reason I go to lecture, they recorded all the lecture, but I go just because I don't want to sit home and lecture. But we have an exam in 2 weeks, so let's see how it goes.
Yeah. Let me mute this here because I can hear him. Okay, so are you in? Yeah. All right, Hip. How you doing?
Okay. Hi guys.
How you doing? You look tired.
Yeah, I have.
What happened? You look so much better last time.
Today I have an OSCE, and I have to wake up at 5:30 to get to school for my OSCE, and I have to study for my. I have to study for my exam on Monday.
I can tell. See, you know, once you get to 4th year, you can be very observant. You can see, you know, how people look. And, yeah. So last time I went to the resident interview, I saw the guys have a lot of callus on his hands. So I was like, that guy's must be working out. So you pay more attention once you get, you know, a little bit further down. All right. So Hip, you sharing the screen?
Do you see it?
No.
Okay, let me
try. Do it again.
Okay.
Okay. All right. So I think there's actually 2 students want to share some cases today, actually. So I'm very surprised. So we have 2 students. So I'm gonna give them, you know, the time to talk.
I have a mini OSCE next week too, so I'm freaking out as well. And the exam the week after, so I'm double freaking out.
Yeah, don't worry. You guys will get through it. Everyone's freaking out the first time, and it get easier and easier.
Yeah, I hope.
Yeah. Okay, let me see if the student is here so that we can let them present the case. I forgot her name actually. Okay. So Hip, you want to go through just the medical terminology and then we wait for the students who come in so they can present the case? Just for now, because I think it's 9 already.
All right.
And then we wait for people to come in more. Okay.
Okay, so with the medical English terminology, right? We have incident, right? And do we have to tell like a definition of it?
Not really. I think that's only for step 1, which we don't have to go into it right now.
So we have incident, right? We have mortality, morbidity, hearing, gout.
No, I think the reason why I put all these because it's relevant to the to the lecture. So that's why just kind of go through how to pronounce this basically. But we just do it quick so we don't have to spend time on it. Okay. So I think the first one is prevalence versus incidence. Let me see. So the reason why some of these are a little bit confused when they talk about prevalence versus incidence. So I guess for step 1, you have to know the the definition for these. So I think incident is with new cases only, and prevalent the total number of cases per year. And the other thing that people get confused is mortality versus morbidity. So that's the other two things. So always go in hand. And then we have uric acid, which is the main cause for gout. So it's pronounced uric acid, and purine, and then gout. So I think it's good for us to learn this in Vietnamese term also, because we're gonna be helping patients with these. So it will help me certainly to translate for Vietnamese patients. Because the other day I didn't know how to translate from gout to Vietnamese. So gout is bệnh gút, right? I know, it's like gốc, so where does that come from? So I think it's gout, but I think Vietnamese people can't say it, so they just say bệnh gút. And then we have the nephrolithiasis, which also the layman term is kidney stones. So it's sỏi thận. And then osteoarthritis, and then the other one is the rheumatoid arthritis, which is the other one that is very similar, but is present a little bit different. So that's the other one. And then the metatarsophalangeal, so which is the one that gout is oftenly, affected. I should have put up the pictures, the classical pictures of gout when you see that mouse, like the one that bite in the first toe and is inflamed. So I think that's actually very characteristic of gout. And then we have cytokines, which is hóa chất trung gian. That's a new term for me. Tophi, what's that? Sanurate? I don't know. Okay, so flare. So I have to ask one of the Vietnamese interpreters for flare. So when you see someone come in with a flare, like COPD flare or acute gout flare or Crohn's flare, so we call it the cup. Okay. And erythematous, basically just redness, and podagra, which is the swelling of the first toe. So like when you write your HPI, instead of writing like, swelling of the first toe, you can write, podagra. It makes you sound like a doctor, I guess. Arthrocentesis is when you actually tap the joint. So that's how you say it. So this one is called Đập khúc dịch bao khớp. Wow. All right. Okay. All right, so let me see if we have anyone want to present the case. Let's see.
Can I make a comment before we start?
Sure. Go ahead, yeah, Jin. Yeah.
So osteoarthritis, I think in Vietnamese is thoái hóa khớp.
Okay. And so what's osteoarthritis is okay. Thoái hóa khớp, and what about rheumatoid arthritis?
They have like, I think there's like viêm khớp mạng, you know, I forgot.
Okay.
I'm actually looking it up right now.
So I think Viêm Sơn khớp is like septic arthritis, right? That's more like infectious.
It's like
joint.
So like it's like it's like
Viêm is infectious, so that's probably septic arthritis. Okay, and osteo is degenerative, so I guess that's right. Yeah, so thoái hóa khớp. Okay, so we have to change that.
Oh, rheumatoid arthritis is viêm khớp dạng thấp.
Okay, what would you say? Viêm khớp gì?
Viêm khớp dạng thấp.
Okay, viêm khớp dạng thấp. Okay, thank you. You know, so that's a very very tricky one. So we all have to differentiate between the three because each one of them have a different underlying disease. So, okay.
That's it.
Yeah, thank you. All right, so let me see who's the student that want to present the case. I think Ngọc Anh, right? Okay, so I have someone from Vietnam who want to present the case about gout. So I will let her talk now. Ngọc Anh, can you hear us?
Yes.
Okay, go ahead. Can you share the screen?
I cannot.
You cannot share the screen?
You have to you have to add me to the webinar.
Oh, okay. All right. I will promote you.
Okay.
You're gonna have a temporary promote.
Yes.
Actually, I can promote you. I don't know why, but I don't know how. But let me see. Hang on.
Oh, I promote her to panelist already.
Yeah.
Can
okay.
she?
Nice. Thanks. Yeah. So, Ngọc Anh, can you share the screen now? Okay. Good.
Okay.
All right. Well, everyone, welcome Ngọc Anh. She's I welcome her because this is a good chance to practice English. So.
Okay. And just one thing I want to.
Yeah.
I just want to help you with the Vietnamese technology.
Yeah.
I just send you and I will help. Okay.
Can you speak a little bit louder? It's hard to hear you.
Okay. Can you see my screen?
Yeah, we can see it, but you gotta be closer to the microphone. It's hard to hear you.
Yeah.
Yeah.
Speak it louder, like
Yeah. Yeah. Is it clear?
Yeah. A little bit, but.
Okay. The case is the chief complaint is the left knee pain, and meets the age of 34 years old male who presented with 3 weeks history of left knee pain. Pain was continuous, and at the beginning the pain was mild, and through time it became excruciating. It got worse with touch and walking and at night, and get better in the morning. He noticed that he had no fever and no morning stiffness. At the time, he used allopurinol daily. And 2 days ago, his knee was red, hot, and swelling. The pain got worse, and he denied to walk. So he came to the hospital. The patient denied relapse, seizure, and blood in the urine of blood used. The past medical history, 2 years ago, he had one acute episode, one acute flare of left first metatarsophalangeal joint pain with the same characteristic and swelling. And the patient was given colchicine, and the symptom disappeared within 12 hours. He was diagnosed gout 2 years ago and was treated with allopurinol and low urine diet. He had no past surgical history. His medication was only allopurinol, and he has no allergy history. About the social history, the alcohol consumption is he drinks 2 glasses of red wine per week, smoking 2 tomatoes per day for 14 years. No drug induced, and his diet, his favorite food was seafood, and he had to eat it every single meal. About a physical examination, the vital sign is 87. Respiratory rate 19, temperature 37.5. The oxy saturation is 97% on room air. His BMI was normal. The general, he was alert and uncomfortable. Okay, no focal neurological deficit. Everything was normal. Okay, just except the joint examination. His left joint was very thin, warm, and swelling, and tender, resulting in decreased his range of motion. No and no deformation was found. About lab test, the blood count normal except the white blood cell of 10,600. CRP elevated at 35, serum uric acid elevated at 644. The left knee X-ray, we see the swollen soft tissue, the ultrasonography. We have the double contour sign of the left femoral condyle. And my assessment plan for him, okay, the diagnosis is acute gout arthritis flare. I think I will change with the history of chronic gout. The treatment, I want to do the acute attack and manage and pain management. In the future, we will provide the prophylaxis to prevent acute flare and lowering the excess stores of urine. Like we should advise him to do the low purine diet, like reduce consumption of seafood and red meat. And I use colchicine and diclofenac to treat his condition. Okay. The summary is a 34-year-old man came in the hospital because of left knee pain. His history of presenting illness, the left knee pain is swelling, and after examining and test result, I found the symptom is the knee inflammation symptoms with pain, swelling, erythema, warmth, and his past medical history. He was diagnosed with gout. Okay, and the valuable signs that is the male sex. He has the past medical history of the first metatarsal phalangeal involvement, and he has previous arthritis attack. He has joint redness and high serum uric acid level, and one interesting sign is the double contour sign on the cell. Okay. This is the end of my presentation. Thank you for listening.
Wow. You know, yeah, I have to say that I'm really impressed with the presentations, because this looks like, you know, a legit, like it's like a representation that a third-year medical student or, you know, a fourth-year medical student here would give. So it's very detailed. So, you know, I really liked your presentation. So congratulations, good job. So just a couple of things, a couple of feedback. So the first one is, I like you have detailed HPI. So that's really good HPI. It gave me all the details that I needed. And then you also include the review system also. So that's good. So the other question I have is, how come you guys don't include blood pressure in the vital signs? So it looks like that details are left out.
Oh,
so,
yes. His blood pressure was normal. Just,
okay. Okay, so that's just one thing. It's not a big deal because it's gout, so blood pressure doesn't really matter. So I like that when you do the physical exam, you just say that everything is normal except. So usually that's how you save time. So only give like pertinent positive. Like if something wrong, then you give it. So that's also good point too. And the lab. So why abdominal ultrasound? I mean, you come in with gout, so like is that a common thing that they do in Vietnam or?
Actually, I just used your presentation.
Oh, no, that's only like a template. So it's only do like relevant exam. Okay, so that's good. So I like your summary, but I can add a little bit more to the summary. So the summary is basically a one-liner. So they use the one-liner a lot here. So basically, it just gives the people that listen to you what kind of like the thoughts that you're thinking about, right? So you're mainly thinking about this patient definitely have gout. So what you can say is this is a 34 years old man with a past medical history of gout in the past who present with acute left knee pain. So and concerning for a acute gout flare. So that is perfectly like a one-line summary for you. Okay, so you have to include the past medical history, which is relevant in here. It's the gout, and also is it acute or chronic? So this is acute, so you include the acute left knee pain also. And sometimes you can include like, the physical exam, say like, but the patient have a benign physical exam also. But this is a clear cut, gout, so this is very good. I really like your presentation. I think you did a great job, okay?
One thing I wonder, like for the HBI, do you have to always include past medical history that relevant to the case into it? And even if, that's the one thing I could, say that always include the past medical history in the first line SBI because it's relevant.
Okay, so that's great. All right, so I think we have another student who's actually want to present a different case. I think it's very interesting. So the first case that you present, clear-cut gout, like a patient come in with, acute swelling of the first, the knee pain and, all that. Maybe knee pain is not that common, but it's sort of acute and it fit with the symptoms because the lab sort of, support it, right? Because he have the uric acid through the roof. CRP is elevated. Okay, all right. So, but the other student is very interesting. So I actually want that person to sort of walk us through the case. So who's the second person who had the case? Can you raise your hand?
Me actually.
Oh, okay. Can you introduce yourself and what's your name?
Let's wait a minute. Yeah.
Okay.
Let me know when you're ready so I can promote you so you can share the screen.
Yeah.
But I don't know how to share my.
So at the bottom it have a share button, so you can just click it. Okay. If you can't do it, then I can do it because I think I have your slides. Can you? And we saw you. So okay. Good.
Okay.
Go ahead. So at the bottom, we have a share button right in the middle.
Yeah.
The green button.
That's it.
Yeah. Great.
This one?
Yeah.
Okay.
Good. Yeah. All right. So before I start, Tan Bui, you did a good job too. It's a very interesting case, but I think Ngọc An beat you with the detail. She has a lot more details than you are. Okay.
Yeah.
Okay. Yeah, but great job. Go ahead.
Yeah. I will start with the HPI first. This guy is a man who is a 42 years old man who have past medical history of gout for over 20 years, and he's and he, oh my God, this is my former version. So okay, this guy presents with the knee pain that's increased when he was active and decreased with rest, and he was diagnosed with knee osteoarthritis and treated by total joint replacement. After the surgery, he stayed in the hospital for supervisions for about 1 month, but his surgical site is still not recovered. So for the physical examination, yeah, I will talk briefly. I think everything is so normal except the, oh my God, I didn't add it here, but his blood pressure is 150 over 90. Yeah, it's quite high. And yeah, this is the former version of my research.
I know. Just you know, go through it. Yeah.
For the muscular skeletal system, as I examined him, for his elbow joints, he's unable to conduct any movement of this joint, and he has a mild pain with his knee joints. Yeah. Okay. So for the laboratory findings, I was noticed the uric acid volume is high. Well, as you can see here very clearly. And when we take his pus samples, we found the Staphylococcus aureus in his pus, and he was treated with vancomycin and tabanic for this infection. Yeah, this is X-ray of his knee joints after the procedure, and yeah, and this is what I want to present you. Yeah, you can see quite clearly here in his elbow. Yeah, that's why he cannot conduct any movement of his right elbow because of this. It's quite large here, and among his toe and finger. Yeah, that's my case.
Okay. Wow. I mean, thank you for taking the image. I mean, that is really severe. You can see sort of that toe thing right there, you know, and also his first toe is really large. So what I like about your case a lot is that it's not, if you notice, you know, from the first case from Ngọc Anh, you can see the severity, right? This guy is a lot sicker than the person that Ngọc Anh presented, right? Because this guy need like a knee replacement, not just, you know, some medication to sort of help with his movement. So this is a lot more severe. And what I like about your case is that acute gout sometimes can, you know, predispose a patient to infection. So as you know, you did tap the patient, you did arthrocentesis, and you take the pus sample out and you culture it, and there's some bacteria that grow. So that's, his picture is sort of like a mixed picture between infection and also inflammatory disease underneath. So that's why this is a lot more interesting case than Ngọc Anh case, because, you know, it's straightforward. But you know, compare between the two presentations, I have to give you a B only because it's missing a lot of information. So for example, if you go back to the HPI, right? I didn't see, you know, like a HPI, like when did the patient comes in? I think because this is your first time doing it, so it's okay. But you know, I think this is not the fixed version I sent to you. I know this is the previous version. Okay. So, but I like that you put in the knee, you know, like a knee pain. So what did the patient come in the hospital for? And you have to kind of introduce us to the course, you know, like what did he do? You know, did he try any medications? You know, like how long has he been sick for? So, you know, so next time if you do another one, to just add those information. Same thing, you know, the social history is also important too. You know, did the patient travel somewhere? Did he get any trauma to the regions? You know, does he stay at home with some cats, some pets, you know, whatever, right? So smoking history, drug, you know, a lot of people use IV drugs so they could inject into the joints, you know, some sort. So those are very important, which you're missing, but, you know, since your first time, it's okay. So we're all here to learn. So, but it's a very interesting case, and I would love to hear more cases like this because it will help us learn as well. Okay. I mean, thank you. Great presentation, both of you. Okay. And I like that. Okay, so I think thank you for the presentation. So now we can go ahead with the lectures. All right, so I'm gonna give it to Hip. Hip, you wanna start?
Okay.
Hip, you wanna start? Okay. Hip, can you hear me? Okay. If you have to unmute, okay, good.
Yeah. All right. So one more question.
So this is a warm-up question. So anyone want to try, give it a try, or just use raise your hand functions? Okay. All right, so we have a couple of people raising their hand. So let me see who. Okay, so is that Main, right? Yeah, Main, you can go ahead.
Okay. Why is gout known as disease of kings? A, because it hereditary. B, because it was diagnosed by a king's doctor. C, because of its association with rich foods. My answer is C.
Huh? Wow.
Do I need to ask?
Brief explanation why you choose it?
Because I think it isn't hereditary. B, because I don't think it related to the disease. And C, because as I know, gout is associated with excess or acid uric in the blood. So I pick C.
Well, because this is also just a fun question I chose from the WebMD website. The reason is the C is right, and also the reason is the non-disease of the kings, because long time ago, just only rich people have money and wealth enough to eat like purine rich food, so that like beer, alcohol, meat, red meat, salmon, those stuff. Those are like good stuff and kind of toxic to the gout. Thing like that, and only like rich people have money to buy those food. That's why it's not a disease but king, because only wealthy people get those and get gout as a result. Okay.
Wow. Thank you. That was interesting. All right, you want to do the second one? Who wants to do the second one? You know what, Min, you can just try it too also, because you sort of answered the question already. So. Kato, you just want to try it? Just walk us through
it. Does anyone want to answer the second one? No? Okay. So eating cheese or low-fat dairy product may reduce the risk of developing gout. Is this true or false?
Right.
Okay.
Okay, we have one person. Hang on. Okay, go ahead.
Okay. Yes. We have two persons. So let two person answer, and then I'll give the final answer.
Yeah. Hoàng Vũ.
I think.
Yeah.
I think eating cheese and low-fat dairy products do not reduce the risk of developing gout. Because I think when you consume fat, it increases insulin, and the insulin will inhibit the eliminating of urine acid in the urine. Yeah, I think so. So my answer is false.
Okay, another person I saw raise hand. For you, are you there?
Yes.
Yes. For you, yeah. What do you think?
I think it's fun because the reduce the risk of the of this disease don't depend on you eating tree. It depends on you this eating a lot of meat. I think that.
But we're talking about the reducing the risk. If you're eating a lot of meat, it's increasing the risk.
Yeah.
Okay. And Hong,
what?
final say. What do you think?
I think it's eating cheese, low dairy products. Maybe
Yeah, low fat. Low fat. The key word here is low fat. And cheese is most of the cheese are low fat.
I think it's false.
Okay, I'm against the war here because actually
I think it is true because you want to because like this one is because of the uric acid, right? So we want to reduce the uric acid intake because in our body we already have the over concentration of the uric acid concentration, right?
Yeah, actually, it's true. Is eating cheese may help reducing the risk of developing gout by around like 36% or something like that. So,
I thought cheese has a lot of proteins and it's a lot of purine.
It's a low-fat dairy.
Low fat.
Okay. Yeah, low-fat dairy. That's
I
the
didn't know
keyword.
that.
Yeah, it's on like
a low-fat diet. Okay, thank you. I learned something. Yeah.
I just learned it today when I tried to search for the question. I think it's very interesting because
you should have asked Sarah.
It's actually pretty interesting.
Yeah, I didn't know that.
Low fat doesn't mean that it's low in protein.
Yeah, so like that's why I'm confused, but you know I take that.
I'm actually looking up. So give me a sec. Well, go ahead. I'll look it up. I'll let you guys know.
Okay, Sarah will have the final.
Okay.
She's a higher, in terminology.
Hierarchy, right?
Yeah.
I'm betting on you. Okay, I'm betting on you.
Hey, but sometimes 4-year students are a little bit better than interns. Sometimes.
Yeah, it's true.
Yeah, let's know a lot of stuff too. So, okay. All right, so I'm gonna leave. Hip, you can go through all the lectures now. Hip is the guy to go to. Okay, you like the main guy now.
All right, so with the epidemiology, right? So this disease happens most in the adults, and it's more happen about in the men, right? And someone say why right here because I think men drink more alcohol and eat more red meat compared to women, and it's happen right. And it have 2 times greater among black men than white men. I think this problem relates to the some genetic factor.
Okay. Yeah, so the reason why I put Y because I put it there. So I just want to see how you guys answer these. So you're right, like the black man versus white man is genetics, but what about men versus women? Like why is it more often in men? So you offer part of the solution, which is a social part of it. Like, men eat more alcohol, but in America, women drink alcohols too, So, yeah.
So actually, because like the it's a difference in the hormone. Like the female estrogen like may protect the female from having gout. Also, the reason like the black men have more like incident than the white male. White men. I think it's partially because of the stigma. Black men, when come to the doctor, is not being here. Like leading to like misdiagnosis a lot. Actually, a new research coming out when you counter for all the factor, they almost have the same incident.
Interesting.
So I just read about it when I see the lecture. I just read about it, and they say that when counting for all the prevalent high risk black male and white male almost have the same like incident of having gout. But they also like say the black male have like higher chance of having hypertension. So I don't know,
so,
like that's maybe a factor.
Yeah, so I think it has something to do with the renal clearance, especially in black men. So the whole problem with gout is how fast we clear the uric acid, right? So I think in females, you're right, the hormone is protected because in female, actually postmenopausal versus premenopausal, the premenopausal women, they have the hormones, the estrogen, which help them clear out the uric acid. So that's why they actually have a lower rate of having gout versus postmenopausal, and also which is why it's lower than men also. So this is something new that I also learned by just doing this lecture. So so that's actually a research paper which I put in the link. I will put up the lectures, the PowerPoint later on VietMD, so people can go to the basically the articles that they propose as the underlying mechanism. Okay, all right. So that's just something that we just need to pay attention to. But I think the most important part of this disease is for the pathophysiology, which I think, Kato, you can go through it.
So, okay, I did not really study the specifically gout, so I will need some help from Hiv and Home to help with the. So the cause of gout, as everybody knows, it increase in uric acid concentration and the deposition of the uric acid crystal into the joint, especially the metatarsophalangeal, like the MTB joint with in the big toe, and that trigger the immune activation and the release of inflammation, cytokine, and neutrophil recruitment. Every time the body have any the biomaterial, even though it's produced by the body, is still considered foreign, and which will trigger the first innate immune system, which is comprised of neutrophil, macrophage, and other stuff. And neutrophil gonna be the first guy to the scene and take care of those things. So so over time, the joint space become irreversibly damaged with chronic pain and deformed joint, and we will talk about it in the next slide about like why and how. So the ultimate product of purine's catabolism is the uric acid, and as we can see on the right side, we can see that diet and nucleic acids both contribute to the purine in the body. Diet can be a red meat, beer, alcohol, fish, some kind of like shellfish. Fish will like raise the level of purine in the body, and we have a de novo synthesis of purine in the body going as well. De novo synthesis means that it's synthesis in the synthesis of purine inside the body, and that the catabolism of the purine will lead to hypoxanthine and to xanthine, and the important enzyme that we need to remember, the rate-limiting enzyme, is the xanthine oxidase. Rate-limited. What's the definition of rate-limiting enzyme? I forgot already.
So the
rate-limited enzyme is the step that where the reaction happens very slow and irreversible. And that's the step for intervention, because as you can see here, we have the two drugs, allopurinol and how to say that?
Probenecid. Probenecid.
It's fabulous.
Rifuricase, you mean? Yeah, that's that's a generic for rifuricase, I think. Right, Sarah?
Okay. So
I don't know that one is.
Okay, so the most common one is allopurinol. So the drug allopurinol function its mechanism is blocking the xanthine oxidase. And since xanthine oxidase is a rate limiting and irreversible step here, blocking it will blocking the production of the urate crystal, as you see down there, down to the line, and that prevents gout attack. So as we can see that the purine, the level of purine in the body, it comprises of diet and nucleic de novo synthesis of nucleic acids. So when the balance of diet intake, synthesis, and excretion are disrupted, it could result in the hyperuricemia. And under excretion account for like 90% of the time for gout, while overproduction is 10%. Overproduction means the overproduction of purine, and under excretion is the under excretion of uric acid, which is a problem in the renal with the kidney system to excrete uric acid. Anything?
Okay, so let me just chime in quickly on this one. So I think for people to understand the gout, so you just look at in the middle. Basically, it's a uric acid problem, right? So it's whether you producing too much or you clearing out your body cannot clear out the uric acid fast enough. It can cause the plasma uric acids to build up. So that's why you have to look at the problem. Either it's overproduction or it's under excretion. So overproduction is when you, whatever you put into your body, let's say you eat too much of the purine product, like red meat, and all that, and then your body break down these through this, this pathway from the hypoxanthine and xanthines. So that's one way that you add in too much of purine product into your body. The other way is actually you under excreting. So a lot of problems that we can cause by taking drugs, for example, NSAID can actually lower your ability to excrete the drug, excrete the uric acid. Also, beer is also the reason why, because we're drinking beer and beer kind of compete with the uric acid, so that's why we excrete less of the uric acid. So that's the reason why we have to look at it both ways. So first, we have to limit the amount of urine that we put in, and the second one is we have to let the kidney do the work to clear out the urine. So that's why the drugs work, at a certain point, so you have to understand where the drug works and how it works. So the allopurinol, it works by blocking the enzyme that Kato talked about. So this enzyme is converting purines into uric acid. You cannot convert the purines to uric acid, then you lower the uric acid level. And then we also do other things to help the kidney to clear it out. So you don't drink alcohol, you don't drink red wine, and you don't take aspirin or NSAID to prevent it from building up to the body. So that's just one thing that we just look at the plasma uric acid level. Okay. Yeah.
Yeah, and I just want to add one more thing to it. Is the uric acid is less water soluble compared to the hypoxanthine. So that's why like when you have the high concentration of uric acid, it will become, if we aggregate together, it become crystal. So that's why we use the allopurinol to inhibit the xanthine oxidase. So when you inhibit the xanthine oxidase, you will increase the hypoxanthine, and the hypoxanthine is more water soluble. So that's why it's easy to squeeze out.
Okay, thank you. See, I already forgot a lot of step one stuff, but that was helpful. Yeah, yeah, great. This is all reviewing our information. Okay.
Okay, so let's talk about like the body reaction when we have the biomaterial as a foreign body. I only know the left side, the right side I need some help. So as I say, like as so as our body have some anything that disrupt the homeostasis, the balance in the body, is will trigger like the innate immune system, which gonna active so the precipitation of urate crystal in the joint will damage the cell around it, and the damaged cell will secrete something called like damage associated molecular pattern, which is a cytokine, the chemokine, and that will attract neutrophil to the scene. So the first phase of inflammation is the migration of neutrophil into like the site of inflamed for the first 24 hours, and the neutrophil will engulf. This will eating the urate acid, the urate crystal, and killing or like metabolite. It will like destroy the urate crystal. And one thing happened down here is the neutrophil is greedy. It eating too much urate crystal and just bursts off. And when it's like explode kind of thing, it will like which is lysis. Lysis means like slow. I don't know what's another word to explain.
Like burst.
Like burst, but layman word, man. Layman word, another layman word. Okay, it will burst and release lysosomal enzyme, which is very acidic, and it can digest and degrade the cell around it, which lead into like the tissue injury and inflammation here. Also, like because neutrophil is only on the scene for like 24 hours. After 24 hours, the macrophage come to the scene, and here we have like the monocyte, and the monocyte will release some the interleukin and TNF. Are these chemokine as well?
Yeah, this is like the IL-1 and TNF. That is the cytokine for the acute inflammation response. So that's why we have fever, swelling, redness because of these cytokines.
Yes. So this also subsequently like activate the neutrophil too, and also can Hiệp and Hùng talk about like the right side, because I did not know about this one.
I think the whole point for this whole you know, slide, just remember that, you know, like the inflammation is driven by cytokines. You know, if even you ask attendants right now what kind of cytokines, they probably shake their head. They'll be like, I don't know. There's a lot of yeah. So this yeah. So like Hip say earlier, you know, just remember like IL-1, IL-6. That's sort of like the inflammatory response to it. I really, you know, don't pay attention much to this, but you know, just remember those, because that's gonna come for step 1 for you.
Okay.
Right. So we can move on to the next one. All right, so Pathophys, so I think we talked about this one a little bit before. So basically, you know, you get from the diet, right? And then they break down the purines to become uric acid. And also our body excrete the uric acid through 2 ways, either renal excretion, which is mainly a lot more than gut elimination. So 70% is renal excreted. So that's why when we talk about gout, we have to see any condition that affecting, you know, like the kidney, the gut, and also diet. That's why, you know, when you go into the room and you think the patient have gout, you have to ask about the question about diet, certainly, and, you know, alcohol, and if they have any kidney problems. So I think we talked about this one previously before. And also people with obesity, actually, they can contribute to, you know, having gout, because when I think of obesity, I think of, you know, systemic inflammation. That's how people sometimes have obesity. Their whole body is sort of inflamed, so it's kind of predispose them to having gout a little bit more than the normal people. And also when people will have osteoarthritis or aging, because their joints already deformed, so they are more at risk, you know, for the crystal to form than normal people, especially when you're old. Also, your renal function is working less than the younger person. So another way why, you know, crystal can build up in the body because, you know, the renal function is decreased a little bit. Okay, so I think for the you can go to the next slide. So when we talk about gout, we can talk about risk factors. So I found, you know, so this calculators, they call it MD calculators, which is all the calculator that you can find. You can do it online. They also have an app, so you can go in and kind of punch in, you know, the risk factors to see whether a person have a high risk factors or low risk factors. So these are all the risk factors you can see, right? So the high purine diet, so red meat, you know, fatty poultry, basically chickens, you know, and then high fat dairy. So I guess cheese, a low fat dairy product, and then seafood. So alcohol consumption. So alcohol, you know, can cause us the kidney to excrete less uric acid. And then surgery, starvation, dehydration. So all this risk factor, you punch in it, and then it will spit out how high the risk of your patient is. Okay. So this is a neat trick you can actually look at. Okay, so we can go to the next slide. So for the clinical presentation of gout, when you think of gout, you should think of, a chronic problems, and sometimes can come in with acute presentation. So gout can be presented with asymptomatic, like people have gout, but because of their, they eat well, they control their diet, and they don't drink alcohol, so their gout sort of control, so they don't really have any symptoms. They can have a little bit of the hyperuricemia, but as long as the uric acid doesn't form crystal, it doesn't form any disease. There's no symptoms for them. And then second thing is acute flares, which is what happened when, a lot of people, when they have this crystal deposit into their joints and they come in the hospital. So this, most of the time you will see is the patient coming with acute flares of it. And then chronic gout, if your gout is not controlled, and your uric acid is, through the roof, sometimes it can form this tophus, or they call it tophi formation, and it can cause joint destruction. So I think one of our student presented a case. You can see the pictures of the, the tophi, which is like sort of like an actual like bump on the skin. So that's actually from the tophi formations, which, the crystal deposit in the little area. Okay, so those three things. So just remember acute flare versus the chronic gout. Okay. And then this is so for step one, mainly you have to understand what's the acute gout versus the chronic. So acute is most likely will be the question, because the patient come in with, really red big toe. So that's the first thing that you think of right away. And you see a big red toe, we call it pedagra. That's just a name of it. Think about gout immediately. And my question for toe and hip is like, why the first toe? Why not anywhere else? But why is the first toe?
Thank you for posting the question, because I actually just researched it.
Okay, good. So these are questions that your attendant will ask you. I've been asked this question before, so yeah, give it a try. Give me, yeah.
Because the first toe, because it's away from the body, and so it had a lower temperature, and the uric acid is more crystallized at the lower temperature, so it find the perfect environment to live, and also like it's related to trauma and level of pH. So it seemed like the toe was like the side that easily to have trauma, and trauma leads to the lowering pH of the synovial fluid, and again, perfect environment for.
I'm glad that you actually look up the questions. Okay, so that's exactly right. So the toe is because it's the furthest away from the body, so the temperature is the lowest. So apparently lower temperatures mean that the uric acid solubility increased with low temperature, so that's why they form crystal more often there. I didn't know about the trauma part, but it perfectly makes sense for me that, the big toe is where people often, bump into or hit other things. So it's more likely to have trauma area to that place. So first big toe, think of gout right away. Okay, not many other joints that you have to think about, but big toe, think of gout. Okay, so and then the other thing is one is, like you say before, inflammatory response, cytokines recruited to it. So we have pain, arrhythmia, swelling, and warmth. Sometimes they have like sort of fever and leukocytosis too. Same reason why, because of the interleukin release. And then the maximum severity is reaching within the 24 hours, so it's very acute. So and when you think of somebody coming acute, symptoms, then think of gout.
All right. I just want to clarify the leukocytosis in case nobody know. Just injury of the white blood cell in the body.
Yeah.
That's what it means.
Yeah. So so when I say it's big toe, I mean it's the most common presentation. But Sarah put up a good point. So it could affect any joint, but when we think of step one, big toe, think of gout. But it certainly in real life it could affect anywhere. So the student presented the knee pain, right? So it's also a pain in the knee, also elbows, basically a large joints. So anywhere possible, basically anywhere that the crystal can deposit to it. And now we can move on to the chronic gout. So the problem with chronic gout is not pain or like sort of acute symptom. This is like chronic problem. The problem with chronic gout is that there's tophi, basically this subcutaneous nodule that comprise of the crystal. This we call the MSUs, or monosodium urate crystal, and it's sort of the crystal with macrophages and all the cells kind of engulfed, and it's formed this large nodule underneath your skin. The problem with this is that your joint is supposed to be a ball and socket. If you have other things that around it, it causes the joint to not be able to move around. So that's why if you have a big tophi in the middle of your joint, you cannot move any of these joints. So that's why people come in with their knee, they cannot move their knee at all, or their arms, they cannot move their fingers at all. So you can see the pictures below. Look at how big those tophi is. So obviously the patient will not be able to move any of those joints. And when you do a not a chest X-ray, but the X-ray, you will see these kind of like, it's sort of like, it's like a hazy little things. So it's not like characteristic at all, but it just sort of, when you do an X-ray and it shows this, and the patient have a symptom fit with gout, and you think about chronic gout. So the uric crystal can also deposit to other body also, organ also. It could deposit to vertebrae, which is your spine. So you could have back pain also. And most of the time it could deposit into the skin. Sometimes it could deposit into your ear also. And also the Achilles tendons, also sort of like a common place for it to deposit to. All right. So just remember, acute is pain, swollen, but chronic is sort of like tophi. They cannot move any of those joints. So the two separate problems. All right. So chronic gout also can have other symptoms also. So like I said before, if the crystal deposit into your kidney, it can actually causes the kidney problem. So people call it chronic urate nephropathy. So the urate crystal can only deposit in the kidney medullary institutions, and it causes inflammation, and it causes the kidney is very sensitive. So if you have inflammation and you have fibrosis, we call kidney disease. So patient come in, you do a BMP, you would say that creatinine is kind of like increase a little bit. So this is just something you pay attention to, but it's most likely you won't be able to see it because gout is very common diagnosed nowadays. So people are often sort of controlled with the medications. And the other thing is also if you have a crystal that damaged the kidney, then you have the kidney damage. So you can see protein in the urine, and they can sometimes they can have like red blood cell and some cell cast in the urine as well. But this is for advanced level. Just sort of pay attention to the renal complications of a person with gout. All right, can we go to the next slide? All right, so how do we diagnose this gout? So gout is mainly a clinical, you look at the clinical pictures, but sometimes you can do a blood test, and then it will show sort of your uric acid level is really high in the blood, but sometimes it's very confused. Like the first case that the student present. So the patient have it's signs of infection and also signs of gout. So how do we tell whether it's infection or gout? So the best way is you take a needle, you tap the joint, and you suck out the fluid, and you send it to the lab, and we call it atherocentesis. So this is the most definitive and also the most valuable test when it comes to differentiate different joint etiology. So when you send that fluid to the lab, they can tell whether is there any bacteria in there, what's the cell counts in there, what's the pH level, and sometimes they can see whether it's a crystal, because a lot of things we can differentiate between a gout versus pseudo-gout is based on the crystal only. So test is atherocentesis, meaning that put a needle inside the joint, take out the fluid. You can also do CBC with gram scan and culture, and then also crystal under the polarized light microscopy. Imaging is X-ray. Sometimes people do X-ray right away, not because they want to diagnose with gout, but morely they want to rule out any trauma. If the patients have a fracture or something, to rule it out quickly. So imaging, sometimes acute gout you can't really diagnose with acute gout, but the chronic gout with those tophi, and the imaging can help a little bit. But normally people, when they have acute attack, when they do an X-ray, it's just so, you know, like some swelling and inflammation, so very non-specific. With chronic gout, then you can see sort of those tophi, which is the hallmark for gout. But I guess the step one question they always do is the classic findings of gout, which they don't give you tophi because it's easy, but they give you this called the punch-out erosions. So it looked like a rat that eat that little bone over there. So it's kind of like they bite the bone. So that's why it's like a punch out erosion. So just remember that. So just remember the mouse bite the first toe and then take out a chunk of that little cortical cortex of the bones. So punch out erosions, remember that it could be gout. All right. Okay. All right, so this is just a slide that I put in. So arthrocentesis, basically it can differentiate, it can help you differentiate whether it's a non-inflammatory versus inflammatory or versus infected. So when you think of, non-inflammatory joint pain, you think of, trauma, right? Like you say, Kato, before, like you hit your toe, you're probably gonna have some sort of inflammation there, but it's not necessary, it's not gonna be like gout or infective disease. So you will see it, like when you send out the fluid inside, you're probably not going to see a lot of cells in there, and everything else will be sort of normal. So when you do non-inflammatory, you think of osteoarthritis and also traumatic arthritis. And after that, you can see the inflammations. So a lot of things can cause inflammation. So rheumatoid arthritis, and also gout, pseudo-gout, lupus. And then infective is obviously it's easy because you can see there's a lot of bacteria. Sometimes the bacteria can grow in those fluid also. So septic arthritis, which is the most common one. TB arthritis, I never seen one, but they always send it to the cultures. Okay, so arthrocentesis most likely will be on step 2 because it's sort of a little bit more advanced, but sometimes they can tell whether the neutrophil is high, then you think of infective process, right? Okay, all right. All right, so now I'm gonna give it to Hip to talk about gout versus pseudo-gout. So because we see it all the times.
All right, guys. So with the gout, the main cause is the deposition of uric acid crystal. In contrast with the pseudo-gout, a cause is because of the calcium pyrophosphate dihydrate. And for the gender, it's more on the gender gout, it's more happen in the males. In contrast with the pseudo-gout, it happens equally. It occurs equally in females and males. And the more frequent affected pain with the gout is more asymmetry, and pseudo-gout is symmetry distribution. And in the gout, they have small joint compared to the pseudo-gout is large joint. And with the gout, I had the acute attack after a long period meal or alcohol consumption. And talking about the joint aspiration, you can see a crystal from the aspiration. And with the gout, you will see a needle shaped compared to the pseudo-gout. It will be a rod shape. And this talking about the polarized light is more of talking about the talking about the organic chemistry. So under polarized light, you will see the negative and yellow lights compared to the positive and blue light. Under X-ray, with the gout, it will be subcortical bone 6, and pseudo-gout is have the colorless calcification. For the treatment for the acute gout and pseudo-gout, it's the same. We need to use colchicine to stop white blood cell migration to the joint. And for the chronic, we use for the gout in the chronic, we use the allopurinol to inhibit xanthine oxidase. And for the pseudo-gout, we use colchicine. for the inhibit white blood cell response. Any question on this?
So let me
comment?
Yeah, let me stop you for 1 second. So this is the money slide. If you want to take step 1. So gout versus pseudo-gout is very common. They always test you on 3 things. First, what is a crystal, right? So you have to know that gout is uric acid. The other one is calcium pyrophosphate dihydrate, just called CPPD. But the most common one I also give you is the arthrocentesis, which is a joint aspiration. So you have to remember that one is a negative bifurcation, and it's always needle shaped. The other one is a positive, so it's blue, and it's a rhomboid or rod shape. But most of the time they test you is a X-ray. When you do an X-ray, pseudo-gout, they always have these condo calcifications in the middle. So it's sort of like a joint, and then we have like a white line in between. So that's a cartilage calcification. So any calcification on X-ray is white. So if you see it, you remember it. So with the gout, remember the little mouse that take a bite out of your cortex. So it left sort of like a hollow in between. So that's the hallmark. Just remember the X-ray, the polarized light, and also the crystals. That's the 3 things you need to know for gout versus pseudo-gout. They're not going to test you for the treatment because they are very independent. It's not very. They don't test you that because even in real life, people just do whatever they feel like it can help the patients a little bit. Okay, all right.
Yeah, this is the cartoon picture I post in, so you can see like it's a cute thing like.
Yeah, so that's why the condo calcification right here. It's a little white line things that you can see on X-ray. So just remember that when you see that little line there, that means they're talking about pseudo-gout. Okay. That's the key questions by the way, yeah. All right, so this is what they look. Sometimes they will give you the pictures. So just remember crystal, yellow crystal, think of gout. And you see rhomboid, I don't know, sometimes rhomboid doesn't really, there's a ton of other things that look like rhomboid, but if they talk about, like a joint pain, then just remember it's pseudo-gout. And one more thing that is sort of connected with pseudo-gout also is, I think it's hyperparathyroidism. I don't know what's the connection, but they always have a person with hyperparathyroidism come in and usually have pseudo-gout as one of the connections that they give you. All right, thank you for the pictures. That's very nice. So, all right. So, like I said before, diagnosis criteria mainly of like clinical pictures. So, but you can do some labs. So, diagnostic criteria is if you have presence of uric acid crystal. That means that you have to tap the patient, take out the fluid, send it to the lab, and there is uric acid crystal in there. Then it's definitive that is gout. The second one is the clinical symptoms, right? And someone with tophi with the MSU crystal, then you think it's gout. And the other one is also we have 6 or more of the following. So if you have asymmetric swelling, acute sort of monoarticular arthritis, means that it's only one joint that's inflamed. You have hyperuricemia, you have joint redness. So if you have more than 6 of this, then you can call it gout. So like I say, mainly these are clinical diagnosis. But if you have a evidence of the uric crystal, then it's a definitive diagnosis. Okay, so the next slide. So we talk about treatment. So this is the money for step 1. So you have to remember treatment for acute versus chronic is very different. So acute is mainly we talk about pain, just help the patient with the pain. So the first treatment that they want you to try is NSAID. So remember so they want to use endomethacins. So this is the treatment right here. So NSAID is the first one. And then if the patient cannot tolerate NSAID, for example, people with gastritis, peptic ulcer disease, and people who have like stomach pain, and you're thinking that NSAID is not gonna, that's not good for them, then you have to use colchicines. So the colchicines, also have side effects, but it helps with patient in these case. So just remember NSAID first. If cannot tolerate NSAID, then use colchicine. And sometimes when you give the patient NSAID or colchicine, but the pain is not getting any better, then you can try the next one, which is corticosteroids. But people usually try to stay away from the corticosteroids because it have a lot of sort of side effects, and you don't want people stay on steroid for a long time. So when I talk about corticosteroids, this could be a A spot dose means that they slam the patient with very high dose of steroid for a short amount of time, or it could be a steroid injections also. But remember, NSAID first and then colchicine later. If they cannot do both, then you do the corticosteroids, okay? For step 1, just remember that. You don't need to know the doses for now. All right, and then chronic gout. Chronic gout is all about lowering the uric acid level. So like I said before, there's many ways. So for step 1, you want to lower the uric acid level. So you can do it by diet change, right? So tell the patient, you know, eat less red meat or purine products. So, you know, low dairy, low fat dietary product like Kato talked about earlier. No alcohol, no beer, and then, you know, so the other thing is you can use the medications to lower the uric acid level. So allopurinol is number 1 drug. You know, you have to remember allopurinol. You have to know the mechanism, like what is an enzyme that is inhibits. So that's why they will ask you xanthine oxidase. Always remember. So instead of saying allopurinol, I just say xanthine oxidase inhibitors, allopurinol. But there's also other drugs too. So we have the I don't know how to say the name, but I've seen it. Uloric also is one of the other medication that can lower the uric crystal level also. And probenecid, so you have to know why probenecid work. So if you go back into like earlier pictures, you can see that sort of probenecid to help the renal, the kidney to excrete the urine, the uric acid level. So just remember these drugs, know the mechanism, how does it work, basically. All right, and we go to the next one. So this is a guideline for acute gout treatment. So I just put it in there for people that actually, you know, taking care of patients. So a patient come in with sort of established diagnosis of gout, and you think of gout right away. Then you can try to treat them first. You know, give them NSAID, give them, you know, colchicine, corticosteroid, whatever. If it doesn't help, then you think about other things. You know, then you tap the joint and kind of send it to the lab and to see what else could be causing the problem. But just remember, acute gout, NSAID first, colchicine, and then steroids. All right. Okay, so I guess that, you know, I go through it a little bit quick because it's almost an hour. So let's see, we can do some questions. Let's see what you guys learned today. And I think this questions, is it my question, Hip? Or this
mine?
Okay, so this is Hip questions, all right. That's good. I like that you write questions because sometimes you have to understand, you know, the test writer, how they make this question, right? Yeah. Okay, so I guess we can read and then we can try to solve it. All right, so let's have one student in our class try to read it. So who wants to read? Just raise your hand. All right, so Đinh Hoàng Vũ, go ahead.
I will
yeah.
mute.
Sure.
Okay.
Go ahead.
A 57-year-old present to his primary care physician with a report of the sudden onset severe pain in his knee and has been present for the past day. He denied any history of trauma. However, he mentioned that he has been binge drinking alcohol over the past 2 days. On physical examination, the physician observed edema and erythema. Severe pain is elicited on the movement of the left knee joint, but there is no overlying skin alteration. On the X-ray of the knee bone shows subcortical bone cyst. So the question is which additional joint aspirate finding would be most characteristic of the underlying disease process? The answer A, neutrophil deactive immune response to cytokine. B, persistent bitter friction rheumatoid withdrawal. C, negative bitter friction withdrawal. And D, thrombocalcinosis. So that's all.
All right. Anyone want to try to answer it? Anyone know the answer? All right, Dũng, go ahead. Tell me how you approach this questions.
negative treatment need more neutron crystal.
Okay. Yeah, go ahead and tell me why. I want to see how you solve the problems. So first question is, what does a patient have?
Patient have he's have a
what disease?
Acute in knee.
Acute what?
Acute pain in his knee.
Okay.
And yes, if
but what disease?
What disease?
Yeah.
I think maybe gout.
We've been talking about gout for like 2 hours, so I think it's safely to say. Okay.
He drink alcohol over past day.
Yeah. Okay.
And
so
he don't have trauma.
Okay. So I think this question is, it's very simple because you think it's gout. Now, there's a couple of clues that clues you to gout. First is an X-ray. It show that subcortical bone cyst, right? That's the hallmark of X-ray. So that's why I say that you just have to remember these key terms. When you see it, just automatically make the connection to gout. Second thing is alcohol, sudden onset, acute. So sort of acute gout, bring on by alcohol. So that's why you have. So when you think of gout, so first you read the question, you know that the patient have acute gout, and then you look at the question, you make the connection, which one of these will, present acute gout. So you think about, so first thing, acute gout is needle crystal, and then it have to be negative bifringent. Okay, so it's positive bifringent, then it's not gout. So that's why I think C is a question is the right answer. All right, so very good job, Hip. So I'm going to go to my question now, okay? A little bit more challenging, but I think it's sort of, it's worth it. All right, so I'm going to share the screen.
I can have a version. You can you can explain about why on the first toe I can hear clearly.
So the reason why we have in the first toe, because it's the furthest away from our body. That's why the temperature will be the lowest, because less blood flow there. So according to some of the research, so the crystal is kind of solubility is decreased with lower temperature. It's actually increased with lower temperature. So the furthest away, the more likely for it to form crystal. So that's why in the toe. And also with trauma, could be more often too. So, do you get it now? All right. So we can do the questions. Can you see the questions? Can anyone? Can someone see it? Right?
I can see.
You might need to zoom in a little bit, I guess.
Okay.
Yeah.
Let me see.
Can you do Control F5 to present it or no?
Yeah.
Oh, wait. Let me see.
View.
Click this.
Yeah.
Okay. All right. Yeah. So first questions. So, anyone want to read it?
Someone raise hand. Okay.
Yeah, Kato, you can help me with that for now.
Lemon.
Yeah.
It's Min. Last time I called her Lemon too.
Well, okay. I'm trying to unmute him.
Yeah.
Okay.
Go ahead.
For some reason, okay.
A 60-year-old female with a past medical history of obesity and osteoporosis presents to her primary care doctor with daily pain in all her knees. She chronic pain that worsen throughout the day, exacerbated with movement and activities. Pain is battle with anxious, I don't know how to pronounce this.
It's ibuprofen, yeah, and rest.
Ibuprofen and rest. She does not have morning stiffness, dry erythema, or systemic symptoms. Besides anxiety, she is also taking anandroids for osteoporosis management. Physical examination is remarkable for capitus in the right knee, mild tenderness and infusion bilaterally. Active and passive range of motion is restricted in both knees. Also, you can do an arthrocentesis. One good to expect to find the bone histologically inspection of the size of this patient is a neutrophils in the synovium with needle-shaped crystal in the cytoplasm. B. Infiltration of lymphoid follicles, plasma cell, and macrophages. C. Neutrophils with bacterial. D. Stenosis, phases of carcinus and subchondral bone. E. Neutrophils with rhomboids and blue crystal under polarized light.
Okay, so my first question for all of you guys is, when you read this, what do you think the patient has? What disease? Well, so we've been talking about gout, but it's not have to be gout, okay?
I think it have to be pseudo gout.
Why do you think pseudo gout?
Because I see systematic symptom.
Mm-hmm.
Yeah, and as I remember, is the problem of pseudo gout.
Remember, I'd say pseudo gout is hyperparathyroidism, not osteoporosis. Okay. All right. So Ngọc Anh, right? Ngọc Anh, you want to give it a try? So what do you think the patient has?
When I read about the information of this patient,
Mm-hmm.
the main diagnosis I think about is osteoarthritis.
Osteoarthritis. Okay. What makes you think of osteoarthritis?
Because she described the pain.
Mm-hmm.
Okay. The pain is she has the morning stiffness.
Yeah.
And arrhythmia and
Okay.
And she get better with ibuprofen and rest.
Mm-hmm.
And we have the physical examination noted that it's limited the the movement range of the knees.
Yeah, I can tell you that you're absolutely correct. I mean, it is osteoarthritis because the underlying disease for osteoarthritis is what degenerative disease, right? Which means that it gets worse with the movement or the usage. So the more you use, the more pain you have, and it gets better with rest. So it's scream out to me that it's osteoarthritis, and it's also better with NSAID too. So that is the first part. You get it right. So it's osteoarthritis. Usually very worse in the morning. I mean worse throughout the day, and usually have morning stiffness. So now out of the 5 choices, which one of these choices tell you that it's osteoarthritis?
Yes, I choose these 12 species of coalescence.
Exactly. So you think of osteoarthritis is like degenerated, right? So you have some pieces of cartilage. These are degenerations of the bones. So what is A? What choice is A? Remember needle shaped?
Yes.
Yeah, needle shaped gout. Exactly. What about B?
B, I think it's some infectious.
Yeah, I mean it could be inflammation, could be infectious. Yeah. How about C? Is usually.
It's also B, like B.
Yeah. So E is rhomboid and blue crystal.
That's total gout.
Yeah. Okay. So I think Ngọc Anh got it, beautifully. I think that's a great job. Okay. So just remember, when we talk about gout a lot, but there's other problems with the joint too. So the most common is osteoarthritis, right? So you just have to remember it's a degenerative disease, which means that you have degeneration of the joints. So the more you use, the worse it becomes. So just remember, if the patient, you know, get pain and it kind of get worse throughout the day, then think of osteoarthritis. All right, so we do the next question. So that's a key. All right, question number 2. So I'm going to read the question now, and then you guys can, you know, try to solve it instead, so to save time. So a 45-year-old female with no past medical history present to the ED, which is emergency department, with increasing pain and swelling of the joints of her hands and feet for several months. She can barely perform any common household task. Biopsy of her synovium of the proximal interphalangeal joint in her hand is shown. Oh, I think I didn't show it. All right. Which of the following would most likely to be positive in the patients? Hang on, let me see. I didn't put the pictures, huh? All right, without the pictures, what do you think?
Well, we have few more people, Kim Chang and Yung.
Yeah, go ahead, just talk, you know. I can't use them.
Yeah, actually, with these kind of like questions, like if you're really good at like testing, I can already guess what kind of disease they're gonna have, just from looking at the answers.
Mm-hmm.
I cannot unmute, so can someone do that for the people that raising hand?
Okay, let's say Kim Chang. Can you?
Yeah, I'm trying to unmute them.
They have
for some
to.
reason
I think they have to unmute it themselves, I guess.
No, I think we can, but for some reason they didn't let me. I don't understand.
All right, so Yung, can you talk?
I'm stop on mute.
Yeah.
Read the question.
No, like you answer it. Well, I already read it, so. So that's the key is the proximal interphalangeal joint, right? So PIP.
I don't know.
Okay, that's okay. So I guess this question is a little bit more challenging. All right, so Kim Chang, you want to speak or? Okay, so we're just gonna go through this. I'm sorry I didn't put the pictures, but it's very, so the question is very tricky in terms of when you talk about the joint of the hand, there's 2 diseases that they always want you to kind of differentiate. It's the rheumatoid arthritis versus osteoarthritis. Okay, so the only reason why I would bring this up the question is because this is a difference. Okay, so rheumatoid arthritis is affect the DIP and the PIP, okay, and but spare the MCP. So just remember those 2. And osteoarthritis is affect PIP and MCP, but it spare the DIP. So when you think about it, right? So rheumatoid arthritis is sort of like autoimmune, you know, a problem. So it's attacked, you know, everywhere. But the distal joints, they tend to attack the distal joints. So just remember DIP and the PIP, but they spare the MCP. So the MCP are a little bit more toward us. So it's more proximal versus distal. And osteoarthritis, if you think about degenerative disease, so that the more you use, the often it will get worse. So when you look at your hands, right, you see that, you know, whatever closer to you, being used more often. So that's why the distal joint is being spared. So that's just a trick how I remember it. Okay. And also when rheumatoid arthritis is an autoimmune. So usually we have morning stiffness, and then you use it, your body kind of get rid of the in the cytokine. So that's why the more you use, the better it will become. Versus osteoarthritis, you have more stiffness, but the more you use, the worse we get. So just remember that. If it get worse, then it's osteoarthritis. If it get better, then it's rheumatoid arthritis. All right. Sorry I didn't put the picture, but let's do the question number 3. All right. So I'm going to read the questions, and then I'll let you guys try to answer it. So a 25 years old college student presented to the ED with a painful big toe. So you can see on the X-ray. So he denied any recent trauma. His toe become inflamed after a night of heavy drinking. Physical exam show that the right first toe is warm, is swollen, there's redness. He was warned in the past that alcohol would exacerbate the pain in his toe. His X-ray did not show any fracture at all. So which of the following enzyme is responsible for the final conversion of the underlying product responsible for this patient presentation? All right, it's fairly easy. We talk about it, so anyone want to answer? All right, I want to have Kato or Hip to answer this question. Either one of you. Hip, you want to try?
Xanthine oxidase.
Why?
You say the final conversion of the underlying products, right?
Yes.
So hypoxanthine will convert to a second product, and the final product is the uric acid.
Yeah.
Right.
Yeah. All right. I mean, it's so easy. So what's the drug that blocks the xanthine oxidase enzyme?
Allopurinol.
Yep,
right?
allopurinol. So remember gout, xanthine oxidase, allopurinol. Okay. And you can see that big toe, right? So the problem here is that this guy have chronic gout. Okay, he was warned in the past that he should not drink alcohol, right? And then he comes to the ED with acute flare of the gout, and then you can see that his toe is kind of inflamed. So I would think that this is probably a chronic problem. So he probably has some tophi in the big toe there. So the enzyme that convert the xanthine into uric acid is xanthine oxidase. So just remember that. All right. Okay, so this is the questions, and just remember that. All right, so number 4. So you have a 50-year-old man with past medical history of gastritis and peptic ulcer disease who present with acute pain in his ankles, toes, and fingers. He reported recent flare-up a few months ago. In recent years, he has developed constant arthralgia at baseline. So arthralgia means that it's joint pain. He noticed a new yellow-white lesion on his ears and Achilles tendons. Pictures are shown as below. On the physical exam, there is significant swelling of the joints, especially in the toes and the knees. So what is the mechanism action of medication will be appropriate to treat this conditions? Okay, so first question for all of you guys, what does a patient has? All right, someone want to raise a hand? Give it a try. Did people read this question ahead of time? Because I posted online. All right, Maine, you want to give it a try?
I think the patient has gout.
What makes you think this gout?
Because the patient has the new granulation on his ear, and I think it's the, I don't know.
Okay, so so you're right. Like he has gout because in the past he had, painful flare-ups a few months ago, right? And so now does he have acute gout or a chronic gout? What do you think?
I think the patient has acute gout because
Yep.
On physical examination, there is significant swelling of the joints.
Okay. Well, I told you it's acute pain, so definitely it's acute gout, right?
And the first treatment we should give for him is to reduce the pain, and I will pick.
So, what's the medication? Remember the 3 medications that we treat acute gout?
NSAIDs.
Yeah. And would you give this patient NSAID?
Yeah.
You would. Anyone have any other different opinions?
I don't, because the patient have peptic ulcer disease.
Okay. See, so they have gastritis and they have peptic ulcer disease. And why don't you want to give them NSAID?
I don't remember the mechanism, but NSAID will make the disease become worse.
Okay. So who wanna answer to me why you don't want to give someone with gastritis and peptic ulcer disease NSAID?
Yeah, I think I know the
sure.
answer.
Okay, go ahead.
Because he got the past medical gastritis and peptic ulcer disease. So if he got NSAID, it will exacerbate his illness. Yeah.
Okay. So when you say exacerbate, what problem will he get if he get NSAID?
For his gastritis, NSAID will will weaken his his protective layers of the gas.
Okay.
Of
so
the stomach.
So mainly you worry about bleeding, right?
Yeah, bleeding.
So exactly. So the NSAID, in this case, you cannot use NSAID. So what's the second drug that you use?
Colchicine.
Okay. So what is the mechanism of colchicine?
Sorry, but I forgot.
Yeah. So that's why these are so tricky, because these are the questions that step 1 will ask you. So anyone know the mechanism of colchicine?
Yeah.
And who say yes?
Hip.
A hip. All right, go ahead. What's the mechanism?
So the colchicine is start to target on the microtubule.
So which cell they affecting the most?
For this, I think white blood cell, right?
No.
No, hold on a second.
What's the cell that come and swallow the crystals?
You say macrophage or neutrophil?
Yeah. So you know the underlying pathophys. Then colchicine block those cells from coming in and swallow all the crystal. So that would help, right? So which would be the answer for this?
A.
A. Okay. So what about B? What is B?
That is NSAID, right?
Right, exactly, NSAID. So NSAID is a COX inhibitor, so it stops the prostaglandin conversion of uraconic acid into thromboxane. All right, so that's B is NSAID. What about C? C is hard. I'm just telling you, it's corticosteroids.
Arachido, yeah.
Like. How about D?
It's blocked the formation of the arachidoneurosis.
Yeah. What about D? Everyone should know D by now.
Allopurinol.
Yeah, D would be allopurinol. All right, and then E, which is completely irrelevant. Anyone know what it is?
Hypertension? Blocking hypertension?
Yeah.
ARB. Yeah. Inhibitor.
Yeah, inhibitors. So it's ACE inhibitors. So, all right. So I think it's right. See, so this question is very tricky because you understand the mechanism. You have to know the treatment, but you have to know the mechanism, right? But sometimes when you study the treatments, you should know the contraindication for the treatment also. Okay, so if you have a disease, it can be treated by NSAID and colchicine. Remember, if the patient have gastritis or peptic ulcer disease, patient cannot get NSAID. You have to get colchicine. So the side effect colchicine is also diarrhea. So if someone have diarrhea while they're on colchicine, then you know that the patient is getting colchicine because he's getting diarrhea. All right, so that's just a little thing that step 1 will kind of trick you. All right, so thank you for everyone for coming to the lecture today. I think that I have a lot of fun, especially with the presentation in the beginning. I think it's very helpful for me and also for all of us. And for the next lectures, I would like to see people answer this question ahead of time. and then try to answer it, okay? 'Cause I think it's very useful in the long run. I will post a question again online again. So anyone have any feedback for this lecture today?
Okay, let me give a little feedback.
Yeah.
Yes, I think this was really interesting lessons that I can learn a lot mechanisms and many other stuff that I didn't learn and explain from my lecturer in Vietnam.
Mm-hmm.
I think you guys did awesome job. Yeah, and but I have one question.
Yeah, go ahead. Yeah.
Okay, so basically we know in the acute flare of gout, the level of uric acid is the patient is high.
Yeah.
And the allopurinol is one of the agents that can lower the uric acid level.
Yeah.
So why don't we use it an acute flare, but we just do it on
So you have to understand what is the problem with acute flares. The problem is you have high uric acid, but some people can walk around with high uric acid, right? They would not have any symptoms. The only reason why they have symptoms is because the uric acid, they crystallize and they form the crystal and they deposit into the joints. So the allopurinol, it works, but then it works along, it takes a while for the uric acid level to be decreasing. So that's why it's more of a chronic management versus acute. So when you think of acute, you want to solve the problem right away. Okay, so that's why you try to tackle the inflammation instead of lowering the uric acid level.
Yes, we use it also with the pain relief like colchicine or NSAID, along with why can we use it along with allopurinol?
I'm sorry, I don't get the questions.
Like in the acute flare, we can also use colchicine, NSAID or colchicine.
Yeah.
Why can we use it along with allopurinol?
I think, they probably, I'm going to believe the answer to Sarah, but I think sometimes, once you're out of the hospital, they want you to take allopurinol. But that's a good question, Sarah. Why they don't start allopurinol at the same time with, colchicine and or NSAID?
So there was thinking in the past that allopurinol can delaying the initiation of your urate lowering drugs if you use it together with like the other medication when you use an acute gout. But right now I think that the thinking has starting to shift to like it's okay, it doesn't worsen the attack or anything. So I think now they start to use it like more regular. But the most important thing for the patient at like the point of having an acute gout is not really the uric acid. It's just the pain that is the most important for them. They do not care about like, okay, my uric acid is high, what should I do? They care about like, oh my god, my legs hurt, what should I do? So yeah, so it's mostly like we treat what is much more important right now. But I think like there's a trend of like doing both at the same time.
Yeah, I think when you come as medication, they try to introduce one at a time, because I feel like if you doing too many medications at the same time, if it doesn't work, they don't know which one doesn't work. So but yeah, we certainly I think we can do more research and see if they recommend doing both. But from my what I've seen so far in the hospital, they want to treat the acute problem first, and when they send the patient out, then they put the patient back on the allopurinol.
Yeah, actually, when I study about gout, my teachers ask us that question, and he don't allow that to use allopurinol at the acute flare of gout, because he explained that it's because it's lower the uric acid, serum uric acid. So basically, there will be the adaptation from our body that will increase when you reduce it in the blood serum. by allopurinol, and then other uric acid from our joints. It will, I mean, it worsens the condition of.
So I think that, you know, when you think of acute problem, it's not the level of the, you know, the uric acid level, you know, it's more of the crystal deposit. So you mean you could lower the uric acid level, but it won't really do anything because it's more of the crystal problems.
Yeah, so I don't really understand what it explains. I want to ask you if.
Well, you know, I'm a student too, so we can get back on that. You know, we can do some more research. So I think the nice thing about us in the United States is that when we have a questions, we are allowed to search for the answer and answer it ourselves. So sometimes I will ask, you know, the attendants some question. If they explain it to me and it makes sense, then I trust them. But sometimes if I don't trust them, I can just go online, look up the answer ourselves. So I can get back to that to you, you know, once we post it to, you know, like the lecture online. But those are good questions.
Yeah.
Right?
So this is the up-to-date version. So initiation of treatment with urate lowering medication is of no direct benefit in treating of an acute gout flare, but ongoing urate lowering therapy should not be interrupted in patient on such therapy at the time of a flare. So basically there is no contraindication of using both of them together, but it just doesn't make sense to them to start like a patient on all 3 new drugs at the same time.
So that's why I feel like if it doesn't have any benefits, though, we're not going to try to introduce it because the too many drugs can cause too many problems. So, all right.
Thank you.
Okay. All right. Anyone else have any questions or feedbacks for us? Sarah, you can give us feedback also. I know you're busy. I don't know why you're here, but you're welcome. Anytime.
Well, my rare weekends off, so I'm enjoying.
Okay. Good
so, yeah, so overall, you guys did a good job. You guys went through like the most basic things. I think there's still a little bit of like differences in level. So I think if you guys can divide like some of the hosts to like go through the chat box and like input some of the information in there so that those who cannot listen can actually like read through it a little bit and understand what we are like talking about, and then hopefully catching up a little bit.
Okay. All right.
And
so
then
so I think I will try to do that next time. So I will have Kato and hit just do the whole lectures, and I just, you know, kind of type in the chat box and answer people. So I think the other thing is the timing also. I always want to do just 1 hour and a half, but it's always run longer than that. So probably we just have to, I don't know. I mean, is 2 hours is too long for people, or is that okay?
2 hours, like most of my class is 2 hours, so I think they should be able to focus for 2 hours.
Okay, we shoot for 1 hour and a half. So that's our goal, is an hour and a half. So today is okay. All right. Any other feedback, anyone?
Yeah, and then I didn't mention it at the beginning, like in the cases, I would love to see some like differential diagnosis in there as well. Cause
so that's the problem, because most of these students, some of them, you know, like MS1, MS2, and then MS4 and SF5. So it's hard to like come up with differential. So at this point,
but I think like the one who like doing the cases is usually like MS4 and 5 to like actually get the cases, so they can actually give a differential diagnosis. So like what did they think when they approach that patient? So we do not like really need to like get all of everyone involved in getting a differential diagnosis list. We just want to like, okay, so when I got this patient, this was what I was thinking about, and then we can go on that.
Yeah. So for now, I want them to get like the oral presentation down a little bit. And I think once we get, you know, a little bit further down the line, some people are more involved in, then we can help them like come up with a differential diagnosis. Because right now they still have problem with writing just the oral presentations part. Yeah. But that will be the you know, the general trend for the future. So having you know, student come up with a differential diagnosis and things like that.
Because that's the fun thing of medicine.
Yeah. But right now we're trying to like get the class together, and like as you can see, it's so hard because people don't. Only few people that, you know, actively answering questions. and I wanted people more to answering questions, and that's sort of fun to do. All right, anyone else have any feedback at all? Okay, so I think in general, I think we finally found like a format for our class. So we will continue to do the case presentation because it's really fun for us instructors and also for students to do their own case presentation. And then we do the lectures, same thing with the case with the topic that we present ahead of time. We post it on Facebook. So, and also I will post the question online so that you guys can go through it and kind of answer the question ahead of time. And tell us exactly like how do you answer these questions, and also for the future we're gonna try to use some PowerPoint that already pre-made by other people, because it takes me a long time to make these PowerPoints, take like hours, and right now I'm okay, I have time, but in the future I won't have enough time to do that. So I think we'll try to use pre-existing PowerPoint. That would be a lot better, and I will write the question myself. So all right, so we'll continue doing that. So hopefully we see all you guys next week. Thank you, Sarah, for coming. Thank you, Kato and Hip. You guys did an awesome job. And Hip, and also what's her name, Ngọc Anh and Tan, who presented the case. If you guys can keep doing that, that would be wonderful. All right, thank you, everyone. Any other questions? All right, so I bid you guys a good night. Sarah, enjoy your day off. All right.
Good job, guys.
Bye, everyone.
Bye. Have a good weekend.
Yep, you too.
Yeah, bye.